Welcome back to Breathe Easy. Episode 25 is part of our 6-part Inhaled TXA series that covers the safety layer around inhaled or nebulized TXA for hemoptysis and airway bleeding. Treat this as staff education, not a prescribing protocol. Follow provider order or pharmacy guidance. The theme is clinical vigilance. Inhaled TXA may help stabilize the clot at the bleeding site, but it doesn't secure the airway. It doesn't replace bronch, embolization, airway control, or surgery. By the end, you'll recognize the dose, verify the nebulized route, and monitor response, spot complications, and escalate early. The mindset shift for this episode is starting the nebulizer is not the same thing as controlling the airway. Hemoptysis turns dangerous when blood interferes with ventilation, oxygenation, or airway protection, and appearances deceive. One patient looks frightening but clears blood just fine. Another coughs up a little but has pooling blood and is in deeper trouble. So control means more than the treatment is running. Keep asking, is the bleeding decreasing? Is oxygenation holding? Is the work of breathing sustainable for the patient? And are suction and escalation standing by? Your assessment makes that call, not the neb. Quick pharmacology recap. Inhaled TXA is a synthetic lysine analog that blocks plasminogen activation and plasmin, slowing breakdown of a fibrin clot. In plain terms, TXA holds on to the clot that's already forming. It's not a bronchodilator, it's not a vasoconstrictor or anticoagulant reversal agent, and it doesn't treat the underlying cause. So why nebulize? It puts the medication right where the bleeding is, often off-label, so lean on the provider order or pharmacy-approved handling. Evidence is strongest in non-massive hemoptysis, and trials excluded really sick patients, and including anyone on mechanical ventilation. Even though here at the medical center we do give inhaled TXA to patients that are on mechanical ventilation, but this is overseen by typically a thoracic surgeon, cardiothoracic surgeon, or maybe an intensivist that is critical care board certified. That is why it's bridge therapy. It buys time, but it's not definitive care. The most common dose in published hemoptysis studies is 500 milligrams nebulized. The frequency follows the order and local policy, which we're still pinning on that right now. Many studies use the 500 milligrams 3 times a day, about every 8 hours, or TID. Some pathways run every 6 in some institutions, but don't change that yourself. Before delivering, you need to verify the patient's name, the concentration, the volume, dose, route, and indication, and make sure that it says nebulized and not IV. Using a vibrating mesh nebulizer like Aerogen when appropriate, or a standard jet nebulizer is appropriate. Let pharmacy prepare or approve the dose, and then we need to talk about dilution. Don't independently dilute or substitute. We only dilute because the medication is very viscous and thick if you're having issues running your specific nebulizer, like your specific equipment you're using. If the patient wheezes, pause and call the provider because this is a response. The highest risk piece is route verification. TXA is most commonly stocked as injectable, but here the order route is nebulized, and that gap is where errors hide. If for some reason you do not see the highlighted order here at your facility, then it's a good chance that your facility does not have a contract for providing this medication. So that needs to go to your respiratory leadership, between respiratory leadership, the doctor ordering the medication, and the pharmacy leadership to ensure that you all have this medication at your facility. And there needs to be a ticket placed. The respiratory leadership is aware of how to put in tickets for Epic. Read the full order. TXA 500 milligrams nebulized at a frequency like QA or TID with an indication of hemoptysis. Verify the patient's identity and that the label matches. Run your rights, right patient, right drug, dose, route, time, documentation, and add your respiratory assessment. Also, document your start and stop time. Document your device you're utilizing, breath sounds, pre and post. Document any type of oxygenation, response, or bleeding. 500 milligrams nebulized is the dose, but once the treatment starts, your real job is assessment. A meaningful response looks less frequent coughing of blood, smaller volumes, fewer clots, easier secretion clearance, a stable or improving saturation, and no new wheezing. Keep expectations honest. Trials measured improvement over hours to days, not seconds. And no response is still data. If bleeding's unchanged or oxygen needs to climb, reassess rather than redose, communicate cleanly to the team whether it's improved, unchanged, or worse. Plus objectives. Inhaled TXA neb started at 1410, patient still coughing up bright red blood with clots, saturations dropped from 94 to 88%. Talk about your intervention and discuss that the medical team was made aware and you've communicated that. Specifics drive escalation. This is not a set it and forget it treatment. The patient is getting an aerosolized medication while actively bleeding into the airway. Get your baseline first. Saturation, any type of oxygen device or support the patient is on. Discuss their work of breathing, their respiratory rate, their breath sounds, secretion clearance, and that bleeding pattern. All of that is within our flow sheet. Ensure that your suction setup is ready along with your manual resuscitation device in case you need it. So during the treatment, watch the patient, not specifically just the cup. Oxygen, look for any types of oxygenation issues, any types of distress, and whether the aerosol is actually being delivered. Afterwards, reassess and document your patient. Positioning like bleeding lung down is a team's call with the provider, so you would have to coordinate that. Nebulized TXA is generally reported as well tolerated, but that does not mean it's risk-free. The one catch is fast bronchospasm, so new onset wheezing, chest tightness, increased work of breathing, reduced air movement, or a change in cough or desaturation during treatment. A concrete anchor in a pilot randomized trial is compared nebulized and IV TXA. 2 patients in the nebulized group developed asymptomatic bronchoconstriction that resolved with a short-acting beta agonist. Desaturation has many causes, such as blood burden, fatigue, poor clearance, device intolerance, or bleeding that's progressing, so take it seriously without assuming the drug's the only culprit. But if it shows up, pause, support, provide oxygenation and ventilation, suction, notify the provider, and reassess before restarting the treatment. When autopilot turns unsafe, if the bleeding worsens, work of breathing climbs, saturation falls, or mental status changes, or you see obstruction, don't let the nebulizer run out because it's almost done. Stop, reassess, look at the patient, support airway and breathing, suction, check oxygen delivery, and listen to poor air movement, and call for help early. Name the red flags: increasing bright red bleeding, large clots, inability to clear secretions, gurgling respirations, weak cough, stridor, or rising in oxygen requirement, persistent desaturation, tachypnea, fatigue, or hemodynamic instability. When you escalate, you use closed-loop communication. Say exactly what changed and what you're doing. What goes wrong is practical and preventable. First, no suction or poor airway prep. If the patient's bleeding, suction is ready before the neb starts. Ensure that you have your emergency equipment at the bedside, such as a resuscitation bag. Second, device mismatch or medication change pharmacy never approved. Ensure that everything is appropriate. Don't dilute TXA just because it's an injectable. Any dilution needs to be discussed with pharmacy, and also look for your delivery mechanics with the type of nebulizer you're using. You don't want to be the one that makes a false mistake. So running a neb must never delay airway control, bronch, intervention radiology, or an ICU transfer that is needed for a patient. And remember, diagnostic uncertainty, upper airway or GI sources can mimic hemoptysis, so describe what you see and escalate. No improvement is data. Unchanged bleeding, a climbing oxygen requirement, worsening distress, or inability to clear the airway each tells you the plan might not be enough. Escalation doesn't always mean intubation. It means the team reassesses. Next step might be a bedside evaluation, a rapid response, ICU support, a bronch, a CT, a bronch artery embolization, you name it. Give a clean RT-focused SBAR, situation, active hemoptysis during or after inhaled TXA. Background, dose, route, time started, oxygen support, and the patient's baseline. Assessment, improved, unchanged, or worsened, plus the saturation trend or work of breathing, and what suctioning shows. Recommendation, a bedside reassessment. And for massive hemoptysis or an unstable patient, inhaled TXA is only an adjunct. It should never delay airway protection or definitive hemorrhage control. This is where respiratory care stays active and not passive. You're often the clinician closest to the airway during aerosol therapy, so your observations are essential. Interpret the response in plain language. Improved means less bleeding or a stable respiratory status. Unchanged means bleeding continues without meaningful improvement. Worse means increasing bleeding, decline in oxygenation, or rise in work of breathing, or new onset wheezing or intolerance. Then say what you see. Don't just chart treatment provided if the picture is changing. Tell the nurse and provider promptly and document it clearly. Your role is clearly a whole arc. Preparation, safe delivery, monitoring, complication, recognition, communication, and escalation. That's what makes inhaled TXA safe, not the medication alone. The takeaway for this episode is the drug doesn't make decisions, you do. Inhaled TXA can genuinely be useful for the right patient, especially non-massive hemoptysis, but the safe use comes down to the route verification, pharmacy-approved handling, and the right device, bedside monitoring, clear communication, and early escalation. Your evidence anchors a 2018 CHEST randomized control trial that used nebulized TXA 500 milligrams 3 times daily for non-massive hemoptysis and excluded massive or unstable patients. Resolution within 5 days was higher in the inhaled TXA group, with no side effects reported. A 2023 CHEST pilot randomized trial compared nebulized versus inhaled TXA, and 500 milligrams 3 times daily in ED patients found higher bleeding cessation at 30 minutes within the nebulized route, with 2 patients who had asymptomatic bronchoconstriction that resolved with a bronchodilator. Your pocket summary is 500 milligrams nebulized is your recognition dose. Repeat only per order. Deliver through that order. And airgen vibrating mesh or standard nebulizer. And don't dilute unless you're fighting the viscosity of the drug itself. Monitor the patient continuously and watch for bronchospasm or desaturation. Never let nebulizer delay definitive airway or bleeding management, and keep your patient breathing easy.